I'd like to introduce Dr. Gordon Baltuch, who's at the University of Pennsylvania, and he's a neurosurgeon there, and has a case for you based on a single MRI.
Thanks, Joe. Thanks to the group from Volume Interactions and Bracco for inviting me this evening. I thought I'd show a case that would be a little more pedestrian. The cases that you've seen, something that though not entirely routine, would be the type of case that I think a neurosurgeon in general practice would see. Not routinely, but maybe within a couple of years, see a case like this and be comfortable with a case like this. As well, I wanted to demonstrate how the type of imaging that we routinely do when we do a navigated approach to a tumor can be incorporated into this system, so that you can actually see a lot more with this system than you could see otherwise. So I'll just present the case, and then we can go through it from the beginning. This is a 19-year-old male who presents to the ED with symptoms of hydrocephalus. He gets a CT scan, and he gets taken right from CT by the resident to the MR, where he gets fiducials placed on his head in preparation for a navigated, or whether it's stealth, main lab, or another system, a navigated approach to this lesion. And this is what you can see is he has an intraventricular tumor. The pathology was neurocytoma. This is what the tumor was. And this is sort of the way you would see this this tumor if you were looking at 3 cuts of MR. You have an idea of what you can see. What Rolf has basically done is he's taken this thin cut MRI, which is a plus, and seeing what he can do with it. How can you better visualize this tumor based on a routine MR in space? And here you can see the tumor in relationship to the ventricles. You can see the tumor in relationship to the pericallosal arteries, which is running on top of it. And you can see underneath the internal cerebral vein, which is and the velamen are positive, and the roof of the third ventricle. And you can see how this tumor is pushing down on the roof of the third ventricle, and it looks like the veins are underneath and being pushed down. You may get some impression of some of the vascular supply to this tumor. So you can get somewhat of an idea looking at this as to what this tumor looks like, which I'm not sure is completely self-evident when you're just looking at the coronal, and axial images. I think once you've seen this, then you can go and start taking a look at when you approach this. I think the 2 conventional approaches to a tumor like this would be frontal transcortical or interhemispheric transcallosal approach. And one of the things that the system can do is it can build a 3D of the brain, and then you could go to the brain and you could see, and this is not an MRI, this is a plus MRI. You can see the big venous drainage, so you can get an idea if you were going to go into hemispheric transcallosal where your veins are, the window you would want to pick in between the veins. If you're going to do transcortical, you can also get an idea of where you'd want to make your corticectomy, and build back, Rolf, and build back to the surface of the case. If you go right back to the surface, you can actually see the fiducials on the surface that were placed. If you add the skin surface to this, and that sort of tells you, you have the fiducials already on the surface. You can already tell where you have to make your incision if you wanted to make an approach, whether transcortical or interhemispheric. So given that, now you can window and take a look as you move through the cortex and see the tumor and move towards the resection. The rest is sort of, as I say, this is not a highly complex case like you saw before. It's something that is somewhat, I would say, more routine, in nature. They often say the only routine case is one that someone else is doing. But I thought this technology, for me, having had the opportunity to use it at Penn, is good for a few reasons. I think being in a teaching institution, it gives us the opportunity to really teach out staff and residents approaches to surgery in an environment where we have time and patience and can go over things. So I think as a teaching tool for us, it's really superb. I think it allows us to see things that we don't see easily with the same images that we're using normally towards navigated approaches. So it doesn't take a lot of different type of MRIs or other scans. Finally, I think in terms of the approaches, it allows you to minimize the approaches, and as well as we move into sort of an area where performance measures are being evaluated very closely, and people are asking us, to operate with less and less morbidity. I think having tools like this, which can provide simulations, offer us as neurosurgeons in the U.S. an opportunity to demonstrate, because you can video this, some of the simulated target practices that you are doing towards lesion resection before you actually go in and do the surgery itself, and use this and record it and have a record of a simulation that was practiced on a lesion before it was actually done. So, thanks, Dr.